Right. We are going to smash some more respiratory questions. And we are starting off with chest x-ray. You review an x-ray of a 34-year-old Afro-Caribbean woman who has been generally unwell, cough, low-grade fever, and erythema nodosa. Okay, doc. What's the most likely diagnosis? Okay, so we're having a look at this chest x-ray. It's not super good. It looks like there you can't really see much of the lower ribs. It's all very black. General low-grade cough, fever, erythema. So we don't think there's a pneumonia here. I can't see any consolidation. Is there some perihilar shadowing? You can get that in some sarcoidosis. Alongside the erythema nodosa makes me think that. PE can't really definitely tell from a chest x-ray. Histoplasmosis, no idea. And there's not much to say HIV, so let's see. Sarcoidosis, it's an easy one. It's a bilateral hilar lymphadenopathy. Yep. Sarcoidosis, extra common in people with Afro-Caribbean ethnicity. We'll take that. Easy. Next. Question 2. We have a 72-year-old woman. She's investigated for some shortness of breath. Auscultation shows bibasal crackles. Fine bibasal crackles. Which one of the following results would be most consistent with a diagnosis of pulmonary fibrosis? The fine crackles making you think pulmonary fibrosis. What we know is that's a restrictive disorder. FEV1 can also be reduced or normal. Let's actually just get rid of all the things which are reduced. We know the ratio might be normal or increased. So let's get rid of those ratios which are reduced. So for FVC, functional vital capacity, it is going to be reduced. And that's going to be normal. Okay, let's go next. Okay, we have a 63-year-old man admitted to the respiratory ward. 4 weeks SOB. Past medical history, COPD, and IHD. Okay. Most likely cause of the patient's presentation. So worsening shortness of breath, ischemic heart disease, COPD. His resp rate is 28, bit high, SpO2 of 86, a little bit low, outside of the 88 to 92 parameters. There are absent breath sounds at the right lung base, dull to percussion. Okay, so it might be something down in the right lung. Bloods are showing white blood cells a little bit up, creatinine a little bit up, don't know if it's baseline, urea a little bit up, lactate dehydrogenase is also a tiny bit up. Pleural aspiration is taken, excellent. Pleural aspirations, I'm pretty sure we're looking for some pulmonary effusion and determining its cause. I think it's Light's criteria. LDH, there's probably a ratio. If we have the blood's LDH, I think that is Light's criteria. It's 330 and aspiration is showing LDH of 1000. End-stage liver disease, that sounds very out there. Let's not have that. Hemothorax. I don't think we're thinking hemothorax with this presentation and history. Heart failure, could this just be some effusion? Potentially. So I think we're looking at if it's a transudative or exudative cause of consolidation in this chest here. Parapneumonic effusion. I feel like there's probably something going on here. There's probably a bit of an infectious exacerbation of COPD. So I don't think nephrotic. Which one is it going to say? I would probably... It's just on one side. I'd expect this to be both sides. So if there was an effusion, this is probably something causing this effusion. Maybe an infection, maybe a malignancy. If I knew more about LDH values, I'd probably be a lot more confident. But let's see. Alright. Hey! Light's criteria. Fine. So Light's criteria is effusion LDH greater than 2/3 the upper limit of serum LDH. points to an exudate. Okay, all right. We're on some good lines here. We've got some criteria down here. Effusion LDH greater than 2/3, upper limit of serum LDH, fine. Pleural fluid LDH divided by serum LDH over 0.6. This question is, what is the most appropriate initial pharmacological therapy to offer? Okay, where are we starting? We have a 70-year-old woman attends a GP with gradually worsening exertional breathlessness over the past year. She has a 35-pack-year smoking history, no previous diagnosis of asthma or allergies, currently takes no reg meds, examination, scattered expiratory wheeze, otherwise unremarkable. Spirometry shows airflow obstruction, consistent with COPD. Eosinophil 0.1, within the normal rate, so we're not thinking asthma, but she's got some expiratory wheeze. You can get some wheeze. She wants to talk about treatment options for symptom relief. Alright, I think this is straightforward. We see a lot of COPD people on some SABA inhalers. First line pharmacological treatment for COPD. In and out. We're on a good streak. What's the most appropriate management step? We have a 78-year-old man admitted with infective exacerbation of his COPD. He has been treated with controlled oxygen therapy, nebulized bronchodilators, steroids and antibiotics. He's had the full shebang. 2 hours after admission, blood gas is performed. pH, this man is acidotic. PaO2 is 7.8. We can maybe assume he's on the Venturi, 28%. PaCO2, elevated. Right? That's what we'd expect to see. And HCO3, also elevated. So this is a chronic CO2. So this is a chronic CO2 retainer. What is the next most appropriate management step? So how is he doing? He's acidotic. Still, after a couple of hours of this therapy, I might be burnt again, but we're talking about maybe giving him some assistance, some BiPAP. I reduce O2, repeat blood gas after an hour. I don't know why we would reduce. His oxygen's still too low. Increase O2 and ABG after an hour. Would we increase his O2? I wonder if we'd get better perfusion with BiPAP. I'm going to stick with BiPAP. Yep, okay. Nice standards recommends patients with exacerbation of COPD should undergo ABGs, chest x-rays, echoes, FBC, U&E, classic. Phenylphylline on admission, if the patient is on phenylphylline. Okay. Sputum microscopy. I'm pretty sure I answered this to a question before. Anyway, blood cultures of pyrexial. You basically do that on anyone who gets a temperature. Fine. Next. Question 6. What is the most likely diagnosis? Alright, let's do some diagnosing. A 57-year-old man presents to his GP, 1 year progressive exertional dyspnea, reports a dry cough, past several years denies expectorating purulent sputum. Patient denies weight loss, hemoptysis, or night sweats. Okay. Past medical history is significant for hypertension, type 2 diabetes. He's worked as a coal miner for many years, 40-pack year smoking history. Okay. Chest x-ray is requested, demonstrating bilateral upper zone fibrosis and eggshell calcification of the hilar nodes. Bilateral upper zone fibrosis, eggshell calcifications. Right. So we don't think it's going to be pulmonary TB. Silicosis sounds like the right thing for eggshell calcifications. I feel like IPF is usually more lower zone rather than upper zone, so I'm going to take you out. Asbestosis, I think this is probably going to be all hung up on the eggshell calcification. Does he have COPD? Did we say he has COPD? I don't think we said he has COPD. He does smoke a lot. Eggshell calcifications of the hyalonodes. And it must be something. This sounds like that. Mining occupation, upper zone fibrosis, eggshell calcifications, query silicosis. Fine. As straightforward as we can get. Silicosis is an example of pneumoconiosis, class of lung disease characterized by the inhalation of dust. Classically presents in miners, pottery workers, prolonged exposure to aerosolized dust particles, usually over decades. Patient may report progressive exertional dyspnea and dry cough due to chronic inflammatory changes. Radiographic features include upper zone fibrosis and eggshell calcifications of the hyalonodes due to the peripheral calcific changes. Alright, I think we're happy with that. Although like silicosis, asbestosis is a pneumoconiosis, occupations are at risk, classically firefighters, dockyard workers and construction workers rather than mine. Furthermore, asbestosis exposure may be radiologically apparent via pleural plaques and lower lobe fibrosis. IPF does not show upper lobe predominance. Okay, so I think we're okay there. Let's hit up the next. A 62-year-old man, recurrent lower respiratory tract infections, is diagnosed with bilateral bronchiectasis following high-resolution CT. Which of the following is most important long-term control of his symptoms? Right, as I have not worked on respiratory, I haven't really had to deal with these kind of questions. So I can only go off some of the people I've seen with bronchiectasis. I don't think that they're on inhaled corticosteroids long term for bronchiectasis, because it's about the outpouching of the alveoli rather than necessarily, well, I guess there's inflammatory changes, but I don't think it's in ICS. Prophylactic antibiotics. He has a history of having repeat infections, maybe surgery. Are they going to do a lobectomy? I know that you can do that with bronchiectasis. Postural drainage, eucalyptic therapy, so is that to cause some better expectoration? Potentially. I've seen people with bronchiectasis on that. I think I might go for that just because of my memory of bronchiectasis. I might go for that just because of my knowledge of what I've already seen. I know that you can have surgery, but it's talking about long-term control of his symptoms. I don't know if he'd have prophylactic antibiotics. Because what does that mean? Is he just going to be on antibiotics the rest of his life? He's just going to end up having a really bad infection. So, let's see. Postural drainage, fine. Symptom control in non-CF bronchiectasis, so non-cystic fibrosis bronchiectasis. Inspiratory muscle training, postural drainage. Postural drainage is a technique uses gravity to help clear mucus from the lungs by positioning the patient so that the affected lung segments are above the trachea. This facilitates mucus clearance and helps reduce the frequency of infections, ultimately improving the patient's quality of life. Alright, let's see where our question went wrong with mucolytic therapy. Involves using medications to break down thick mucus secretions, provides symptomatic relief. However, overall benefit long term remains uncertain and is not considered the primary method of managing symptoms of bronchiectasis. Here we have a 19-year-old lady presents to GP, past medical history of asthma, is taking ethalbuterol. She was recently started on a new drug after a few weeks of intake. She has noticed several white patches in her mouth, accompanied by a loss of taste. Which of the following medications is most likely to be causing her these new symptoms. We know it's definitely going to be I don't think that exists, but it's going to be a steroid. This is going to be oral candidiasis. Patients taking inhaled steroids to treat asthma are advised to rinse their mouth to prevent the development of oral candidiasis. You don't need to think about that. That's just simple things are simple. Oh. Right, we now have a 36-year-old man presents to GP annual asthma review. Symptoms have been very well controlled over the past year. He does not use his salbutamol at all. That's pretty good. That's perfect. That's gold standard asthma control. He currently uses an ICS 200 micrograms per puff, takes 2 puffs twice a day. On examination, he appears well. An examination is normal. We don't know about his history, how he's been titrated up, how reliable he is with taking it. It sounds like he's smashing the asthma control. I wouldn't change. Maybe change it. Step down treatment of asthma. Aim for a reduction of 25 to 50% of the dose of ICS. Alright. That's what the question says. Next question. It says the man presents at A&E shows some breast and weave after a recent change in medication. Okay, so we're basically following guidelines here. That's what it should be done. A 55-year-old patient was admitted to the intensive care unit 5 days ago with severe COVID-19. On assessment today, he is dyspneic, and medical team suspects that he might develop ARDS. What finding on assessment would be consistent with this diagnosis? Okay. If he's developing ARDS, come with severe COVID-19, what would we expect to see? So he's going to be working very hard. I don't think there's any room of amylase in this. Bilateral infiltrates, potentially. Maybe, I imagine you might see stuff on the lungs. Maybe some patchy consolidation. Echo showing abnormal left ventricular systolic function. I don't think so. We're not talking necessarily about the heart or heart strain in a ARDS diagnosis. Raised pulmonary capillary wedge pressure. Okay, so this is going to be looking at the right atrium and the pressure there, and that would be signifying, is that pulmonary capillary wedge pressure? So this is going to be looking at the pressure in the atrium and thinking of an increase in, I don't know about this, I'm going to go for bilateral infiltrates. That's what would make me feel most confident. Alright, here we go. Diagnostic criteria for ARDS. Clinical chest x-ray, PO2 or FiO2 under 40 kilopascals. We didn't even talk about that. Chest x-ray with diffuse alveolar opacities is consistent. Patchy consolidation. We'll take it. But with the Berlin criteria, obviously. Other criteria include an acute onset within 1 week. A PO2 and FiO2 is the, fraction of inspired oxygen? Something like that. Under 40 kilopascals. And expiratory failure not fully explained by cardiac failure or fluid overload. Hey, what interventions can be offered to the mother and or baby? Alright. 31-year-old gravida 1 para 0, the first time pregnancy. Or, let's carry on. Is she pregnant? Yeah, mother and or baby. Okay, yeah, she's pregnant. Alpha 1 antitrypsin and COPD presents to respiratory clinic after finding out she is pregnant. Alright, we're jumping the gun. She's concerned about well-being of her baby and risk of inheriting alpha 1 antitrypsin. Okay, so we're thinking genetic causes of things. What counselling would we actually give? Maybe counselling when they reach adulthood. I don't think we need to do fetal testing or anything like that. Oh wow, okay. We do genetic counselling and prenatal testing of a fetus. Is this something that we do from a blood test? I don't think we would do some like amniotic screen or anything like that. Genetic counselling for alpha-1 antitrypsin deficiency will involve counselling regarding absolute tobacco abstinence, avoidance of noxious inhalants, and as well as the risk of liver disease. Okay, I don't know how we diagnose it prenatally, but maybe it's just a blood test.